Hello, everyone, and welcome to today's live broadcast, Exon-level array, bridging the gap between chromosomal microarray and next-gen sequencing, presented by Dr. Nicole Deleu and Dr. Christina Kuzmano-Ozog. I'm Alexis Krause of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Thermo Fisher Scientific. For more information about our sponsor, please visit thermofisher.com. Now, let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. We'll answer as many of your questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Answer a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now introduce our speakers, Dr. Nicole Deleu and Dr. Christina Kuzmano-Ozog. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Deleu, you may now begin your presentation.
All right. Good morning, everybody. I'm happy to show you our validation results of the new CytoScan XON Array that we tested in our lab in the past 2 months, in March and April. And just to let you know that we've been using the CytoScan HD array for nearly 7 years now, and we're doing about 2,500 arrays a year. And for the HD, it's known that it's a very high resolution array with a theoretical resolution of about 1 kb and practical resolution of 20 kb. The detection criteria that we use in our lab is that we have losses at least 10 kb in size with at least 10 probes, for gains 20 kb in size, and again, more than 10 probes. For the reporting criteria, we only report those CNVs that we detect if they're larger than 1 kb, but if it's in a region with an OMIM disease gene which matches with the clinical features of our patient, then we also report smaller CNVs, so larger than 20 kb. On the other hand, if there's no protein coding gene in the CNV region, then we only report the CNV if it's larger than 500 kb. In addition to the CytoScan HD array, we also use CNV in our exome data because we've been using whole exome sequencing in our lab since 2011. And since 2014, we routinely also perform CNV and exome data analysis on all exomes. Now, the average resolution for the CNV and exome data is for a 50 MB exome about 100 to 200 kb genome-wide. But of course, for the exomes, the targets are the exons. And so for our pipeline, the calling criteria are at least 3 exons. Then there is a call. And that's only done in line with consent of the respective gene panel that has been requested for a patient. Now, for the reporting criteria, those are also in line with consent. So either gene panel or gene panels and open exome. For both approaches, both HD array and exome CNV, we sometimes encounter CNVs that we need to validate, so then you need to do MLPA. So when we were informed that the CytoScan XON Array was available on the market last year, we were very curious to find out how well it performs, especially because this array has almost 7 million markers, so we were quite impressed by the number. And therefore, we decided to, that's right. So the nice thing with the XON Array is that the probes are highest coverage covered on the level 1 genes. Those are the ones with the highest evidence for clinical relevance, so known disease genes. And then the other 3 levels have fewer probes per exon, but still are quite nicely covered, which you will see in a minute. So as you can see on this slide, the level 1 genes are targeted not only on the exon region, but also the flanking regions before and after the exon, whereas the level 2 and 4 genes are only targeted for the exon itself. Within our validation study for the CytoScan XON Array, we not only looked at the genetic sex, which is important, but the main thing is the QC parameters, and we used those settings, those values that were put up by Thermo Fisher, as depicted here. And then obviously also we would like to determine the sensitivity, the specificity, and the reproducibility. Then for the validation study, we performed a total of 78 arrays in 9 runs with 1 run per week, and 3 technicians did all the work. And those were the 3 names that you saw on the first slide. Now, for the validation purposes, we used a Thermo Fisher DNA reference sample, number 103, and we used that 13 times, so on 13 arrays. And in addition to that, we had DNA from 5 unaffected parents, 1 DNA with the normal test results after array, whole exome, and whole genome sequencing, and also a water sample. In addition to that, we also had multiple samples with a known CNV detected by either CytoScan HD, CNV in exome, and or MLPA, and also a number of possible CNVs. So we were not quite certain whether or not that CNV was indeed a true positive. We not only used DNA from EDTA blood, but also from amniocytes as well as fibroblasts. We had 34 male samples, 23 female samples, and 1 sample from a 46XX male. 43 deletions were included, and 12 gains, and 4 CNVs that were needed to be validated by another test. So these are the results from the 9 different runs that we performed in our lab. This is the SNP QC value. As you can see here, should be larger than 10. The majority of the runs were fine. Only run 4 was quite with quite poor results, but all other runs were quite nicely below, above 10. For the MAPD, that should be a value below 0.2, and again, only the run number 4 did not qualify here. And again, the waviness SD, which is an important QC parameter, that should be less than 0.8, and only run 4 was really dramatically above. All others, the majority was below, but 2 were suboptimal. Now, for the detection analysis, you obviously need to set your filters. On the far left, we show you the filter settings that we use for our HD array. And the middle one is those values that we decided to use for the XON array. And if you do not have any filter settings apart for the size, then you can obviously detect more, but you also get more noise. And here you see from one of the arrays, I show you the segment number that were called, and here you see 46, 63, and 172. And this is what it looks like for the whole genome view, and the little bars here indicate the segments that were called. Now, if you compare in CHAS 3.3, how it looks for the HD array and for the XON array, you see the copy number state indicated by a triangle for the HD and by a vertical bar for the XON. The log2 ratio are basically the same. Only for the XON array, there is now also a summarized log2 ratio. For the genotype information, that's basically the same for both platforms, only for the exon array, you also have the so-called B allele frequency that you can select for viewing. The nice thing is that within CHESS, you can load at the same time both exon and HD array samples, so you can compare the two in one view. So that we really liked. This is an example. This is a finding that we had in a boy, 5-year-old with mild intellectual disability and autism. And there you see that with the HD array, we found 180 kb deletion, and it's on chromosome 18, including the TCF4 gene. Now, as you can see here, this is the exon array result. And you also see a deletion, but it's seemingly smaller. However, this is where you need to look at your graph settings because you need to get a little used to the CHESS settings. So when you click here on automatic dynamic range, you clearly see that the loss is much clearer with this setting. And therefore, this was confirming that this CNV was called also by the exon array. Let's see what I have here. Oh, yes. Here I want to show you the coverage of the probes for various genes, going from fairly large genes such as TCF4. Here you see it on the HD array, the probe coverage, and here you see the exon coverage for that specific gene, the TCF4 gene. Now, next one is the EHMT1. The gene known to cause Kleefstra syndrome if it's mutated or deleted. Again, nice coverage on both platforms. But if you go along, this is RIDE1, also nicely covered on both platforms. But if you notice that the smaller you get, the better the coverage is for the exon array. Again, this is still a nice coverage on the HD. But if you now look at the ELN gene in the 7q1123 region, you see that for the HD, it becomes more difficult. Here are the different exons in this gene, and you see basically a gap here on the coverage in the HD, but the exon is really nicely covered. And even smaller, the SHOX gene, 35 kb in size, but it's really nicely covered on the exon array. Now, I was curious to see how many probes are there on those specific genes that I just mentioned for the exon 1 and exon 5. Here you see the number of probes for the HD platform, and there you see on the right-hand side the probes on the exon array. A tremendous increased number for the exon array, so really impressive. Now I'm going to show you a few samples from patients that were used for validation purposes. So this is the first one. This is MLPA and gene mutation analysis that was performed for the STK11 gene in a 15-year-old boy with pigmentation on his lips and a high incidence of cancer in the family. And so the clinical suspicion of Peutz-Jeghers syndrome. And with the MLPA, there was a loss of at least exons 5 to 10 for the STK11 gene. So the requesting clinician wanted to know how big the actual deletion is. So for characterization purposes, we used the CytoScan HD array, and there we found 150 kb loss in chromosome 19. However, that was distal of the STK11 gene, which was quite surprising to us. So we used different reference sets, but nothing changed for that matter. We still did not detect a deletion involving the STK11 gene. So therefore, this was also a sample used for validation on the exon array. And here you see the HD result and below the result for the exon array. And you clearly see that this deletion is bigger on the exon array. If you zoom in, then you see this is the HD deletion, and this is the entire deletion on the exon array. And there This is zoomed in. Here you see the aberrant region detected by exon array. And as you can see on the left-hand side, the breakpoint is in the STK11 gene, and this is a 200 kb loss in exon 5. The breakpoint is in exon 5 of this gene, which is in agreement with the MLPA findings. Next is are the results of the array in a boy, 7 years old, with sensory neural hearing loss. First, GJB2 and 6 sequence analysis did not reveal any variants. Then exome gene panel was done, and there we found a nucleotide variant on one allele and a gain on chromosome 12 on the, we don't know, but so we had a CNV and an SNV in this boy. So this was one sample that we also performed exon array to validate the finding with the CNV and exome analysis. Therefore, we focused on the autoglycan gene in this case. And this is what it looks like. This is the autoglycan gene here below. And there you see the gain on the left-hand side. If you zoom in, it looks like this, and the first 6 exons of this gene show a copy number increase. If you compare this with the CNV and exome data, it really matches nicely with each other. And one reason to validate the finding of the CNV and exome data is that the finding, the call for exon 2 was seemingly normal, but now with the exon array result, we can confirm that it's really the first 6 exons that show a copy number gain. Next is an example. That was a newborn baby girl. Prenatal array was performed, did not reveal any imbalances. Then turbo trio exome analysis was performed with the OMIM disease gene panel. Thereafter, open exome analysis, but no variants were identified. Then the clinician requested a reanalysis of the data because the baby died at 7 months of age. And then they asked us to look at certain genes. And one of them was a de novo variant in the FAT4 gene. That is associated with a recessive disorder. So we were curious and we wanted to know whether perhaps there is a copy number gain or loss on the other allele. So we performed exon array, but unfortunately we did not reveal any, we did not detect any CNV there. I include this example, these data to show you more on the nebulin gene, because this is a quite large, it's an impressive number of exons for this gene, but it's also a difficult gene because of the various repeats within the gene. And here you see the CNV and exome data, and in the middle you see a gap again, and that's because in that gap there's a repeat sequence. And so this region is not covered on the exome. So we were curious to see what those data look like for the array. Again, here this is the region enlarged, multiple exons within that repeat region. And this is the result for the HD array, the prenatal HD array result. That does not reveal anything, any imbalance. There's a minor dip in the one region. And here with the axon array, there seems to be a loss in that repeat region. So just to make sure, we did look in the exome data again, because a severe form of nebulin disease could also lead to hydrops fetalis, and that was also encountered prenatally in this fetus, but we did not find any nucleotide variant in this child in the nebulin gene. Next is an example, again, a prenatal array was done because of nuchal translucency and hydronephrosis. After that was observed at 19 weeks of gestation. And there we found 100 kb deletion in chromosome 6 within the ARID1B gene. It turned out to be a de novo gene, and therefore this was also included because it only had one exon deletion here. It was a de novo one exon deletion in ARID1B. As you can see here, these are the exon array below, and there it's also detected with this. I zoom in here, and there you see that that one exon is clearly deleted. And it seems smaller, but that's just because the focus for the exon array is on the exons. Next example, we go even deeper than, so within an exon. This was a finding we had in a intrauterine fetal death at 33 weeks of gestation. And there we found a very small loss, less than 1 kb in size, 8 probes, and it was within exon 1 of the JAK1 gene. And we were curious to see how that looks on the exon array, and sure enough, the deletion was indeed confirmed by the exon array. Not only that, also the exon 3 and 4 seem to show a copy number gain. So we are not certain whether that is a truly clinically relevant, but it definitely could, because those gains of 3 and 4 have been reported in the JAK1 gene. Next are the data of exome sequencing in a 7-year-old boy, where we did the hearing loss gene panel. No SNVs were found, but with the CNV and exome, and confirmed by MLPA, the proband had a homozygous loss of at least exons 25 through 29 of the SDRC gene. Mother turned out to be a heterozygous carrier of a deletion, but father revealed a normal copy number for that region. Now, if you look into that region on 15q15.3, there's the SDRC gene, there's the CKMT1B on the far left side, and the stars indicate the locations of the MLPA probe. Also covered by the MLPA is the Catsburg2 gene, because often you want to know whether or not that gene is also deleted. Now, the problem or the challenge with the SDRC gene is that it's part of a tandem duplication on chromosome 15, and the second copy is in a pseudogene. So that's really a challenge to analyze and interpret this gene. So if you see the HD coverage in this view of the UCSC genome browser, you see incomplete coverage of the SDRC gene for both the HD and, as I indicated, also for the MLPA. If you look on the exon array, it's really nicely covered for all exons involved. And we applied this, we included 3 samples from a trio. So on the upper left, on the upper part of the figure, you see the homozygous loss of the index patient. You see the father who shows a normal copy number, and the mother who has a heterozygous deletion in this region. So here you really see a nice example of homozygous versus heterozygous. So our conclusion for the validation study results is that for all the arrays that we performed, we had to conclude that 1 or more QC parameters were not met in 53% of 78 arrays. As far as the sensitivity is concerned, 46% was called with filter settings that were also used for the HD. 91% were called without filter settings, and all of them, so 100%, were visible in CHAS upon inspection. As far as the specificity is concerned, no relevant CNVs were detected, and reproducibility improves and is still getting better with every run. What I want to show you next is that after having run several, 76 array experiments, we decided to use a majority of those data and use that as a new in-house reference set. And here you see in this table the QC parameters for both old reference set, the standard reference set, and our in-house exon reference set. And you see that for all QC parameters, the values have improved, indicated by the green color. Only a few red ones are shown or are seen. And also, if you look at the far right column for the calls, you really see a dramatic improvement in the number of calls, because if you need to go over 100 segments or more, then that's really tedious. But if you stay within between 5 and 15, that's really nicely doable. So just a few more slides to show you after the validation study of a few results that we had made in the recent weeks. So one example is a prenatal array request because of several structural ultrasound anomalies. The child was suspected to have Meckel-Gruber syndrome, and there we found a very small deletion on chromosome 12. After the parents decided to terminate the pregnancy because of the severe ultrasound structural abnormalities, after that, CNV and exon trio analysis was performed on DNA from the fibroblast from the fetus. And there we found an intragenic homozygous loss in the TCTN1 gene. And that is the same loss that we detected by HD array. And so we were wondering, because there it was a heterozygous loss, or seemingly heterozygous loss. So we next performed another HD array on the same sample as was used on the CNV in the exome data. And again, it was identical to the previous prenatal array sample. So again, this was strange to us that we detected a heterozygous loss with array, but with exome, we really saw a homozygous loss. And for both parents, we saw a heterozygous loss for each of them, which matches with the fact that the child has a homozygous loss. So the conclusion was that both are carrier of a heterozygous loss, and the child was affected due to homozygous loss in the TCTN1 gene. Now the couple is pregnant again, and they are thinking about prenatal diagnosis. So we were wondering what the best test would be. And I said I would go for the exon array. So that was the next step. We did exon array. And here you see the example of the HD array below in light blue, and the violet in the exon array on the fetal DNA sample. If you zoom in, oh no, sorry. And next, we also did the mother DNA on the exon array. And here you really see that in the fetus, there is a homozygous loss, whereas in the mother, there is a heterozygous loss. So that was matching with the CNV and exome data. And as you also can see, the homozygous loss in the fetus is within a relatively small homozygous region that was we think due to identity by descent, which matches with the fact that both parents have the same heterozygous loss, but no other homozygosity detected. Final slide, and this was just because I was curious to see how the coverage on the exon array is for non-coding regions in the human genome, and especially the enhancer region upstream to the FOXF1 gene on 16q24.1 is known is an important region to be able to detect or analyze, because that has been shown to, if it's deleted, it can cause alveolar capillary dysplasia with misalignment of pulmonary veins due to FOXF1 haploinsufficiency. So that region is nicely covered on the HD array, but if you look on the exon array, I was happily surprised that was also really nicely covered. And this is the thing, that region is not covered on the exome because it's not encoding. So in conclusion, our validation study results demonstrate that the CytoScan HD array is, the CytoScan XON array is a suitable platform to detect CNVs at the exon level, that it yields really nice results for various, with DNA samples from various tissues. and that it's currently, in my opinion, the best option to test multiple genes for intragenic CNVs in the human genome, because definitely not for all genes there is a MOPA test available. And also genome-wide analysis is possible within for the exon array, although it's lower resolution than achieved with the HD array, but it's a higher resolution than you can achieve with CNV and exome data. So with this, I would like to end and thank my colleagues in the department, and I'm happy to answer any questions you might have. Thank you.
Thank you for inviting me to share this presentation with you. Today, I will discuss our experience with the XON Array at Children's National in Washington, D.C. I'd first like to give an overview over copy number variation. As we're all aware, this is an important determinant of human diversity and plays a significant role in disease susceptibility. There's about 1.2% difference between any individual in the reference genome. In an exact study of almost 6,000 individuals, over 126,000 copy numbers of variants were noted in protein coding genes. And on average, most individuals have about 0.8 deleted and 1.75 duplicated genes in their genome. Most individuals will carry at least one rare genetic copy number variant. Of these changes, 84% are smaller than 100 kb and 50% are shorter than 20 kb. Children's National is one of the largest clinical genetics programs in the United States. And last academic year, approximately 8,000 individuals were seen in the genetics clinic. The individuals evaluated in clinic are a very diverse group. Of the 8,000, approximately 500 were noted to have developmental delay, another 500 were noted to have autism, and a little over 1,000 were seen because of an inborn error of metabolism. And as we're all aware, the evaluation of a case in the genetics clinic often includes recommendation for genetic testing. In 2013, we went live with chromosomal microarray, and at that time we're using the CytoScan HD system. As we're all aware, this is a first-tier test for the evaluation of imbalances associated with intellectual disability, autism, and multiple congenital anomalies. In August of 2014, we transitioned over to the CytoScan Dx system. It's a 510K cleared chromosomal microarray, cleared for postnatal use for cases of developmental delay, intellectual disability, multiple congenital anomalies, or dysmorphic features. Following our go-live of chromosomal microarrays, we proceeded to in-source next-gen sequencing. In 2015, we went live with next-gen sequencing. And our approach was to use a medical exome kit as opposed to going live with whole exome sequencing. In our laboratory setting, we treat all samples the same on the wet bench and sequence all genes for every sample. We then bioinformatically filtered the genes to only those that were ordered for the patient. This allows physicians to order either a predefined panel, such as cardiomyopathy, Noonan, or epilepsy, or this allows the physician to order a custom panel based on either a phenotype-driven approach based on the clinical indications noted in their clinical evaluation, and it also allows us to leverage our microarray results to look for recessive disorders in areas of homozygosity. This is especially important in our patient population, as approximately 5% of all microarray results in our laboratory have greater than 2.5% areas of homozygosity consistent with consanguinity. Additionally, if testing is negative, we allow the physicians to have a free second look, which minimizes cost and analysis time in the lab in hopes of also decreasing the number of VUSs that the physician receives on the report. Even with moving forward with next-gen sequencing, there was a strong desire from our clinicians to also have CNV analysis as part of this testing. We then decided to approach the validation of CNV analysis via our next-gen sequencing. The way we approach this is by using BWA and GATK to call SNVs and short indels. The BAM file is then fed into the NextGene software, and this detects copy numbers by comparing the coverage of the sample to the coverage of controls. Coverage is measured as a standard, and probabilities are entered into a Markov model. During our validation of copy number bioinformatically, we examined 122 CNVs. 109 were previously discovered by another method or an outside laboratory. These included 66 deletions and 43 duplications. Additionally, 7 negative samples were verified. However, during our validation, 4 single exon copy numbers failed to be detected, and 2 single exon that had not been previously identified were thought to be found by our validation. As you can imagine, this was less than acceptable when we were doing our validation, and really made us cautious in saying that we were doing a good job on copy number analysis by next-gen sequencing. Single exons is a known limitation of bioinformatic copy number analysis. And even though it's a known limitation, it still made us uncomfortable to declare that we were able to do this appropriately. So 4 of the 11 that were single exons were not identified during our validation. And even if we were to have moved forward and called this a validated process, we realized that there was still a need for an additional confirmation of any CNV call that would be reported out. And so the question came up of, would we use an alternate platform, or would we use a secondary method of CNV calling, such as Bayesian analysis? Thankfully, as we were in this conundrum, CytoScan XON Array became available. And so we first started utilizing XON Array in April of 2017. And that was really just the process of getting to know the workflow and the wet bench and being able to process samples. We completed our training in October, and kits are now available for use for all individuals. Kits can be used with the existing thermoscientific equipment, i.e. if you have the CytoScan HD or DX system in your laboratory, you can supplement the equipment already in your laboratory by purchasing this kit. And one of the really neat things that we were able to accomplish in our lab is that the medical technologist that is assigned to prep our CytoScan DX assay, which is run on a weekly basis, can also run the CytoScan XON concomitantly, which meant, at least in our laboratory setting, no additional FTEs were required to bring this additional test in-house. So quickly to compare the Dx and XON arrays, the Dx array has 2.7 million markers for copy number analysis. They're approximately 880 bases apart in the genic regions, and approximately 1,700 bases apart in non-genic regions. Additionally, there's 750,000 SNPs to aid in the detection of homozygosity and/or uniparental disomy. Comparing this to the XON array has 6.5 million probes, so it's a significantly larger number of copy number probes. However, it has significantly less SNP probes with only 300,000. The DX system is meant to cover the entire chromosome in broad swoops, whereas the XON array is really focused on genes of interest, with the level 1 genes being genes that are in omen with known disease or phenotypes, and moving down to levels 2, 3, and 4 that are genes with significantly less knowledge known about them. I would like to talk about some clinical cases that we have had in our laboratory setting to compare and contrast and to illustrate why you need both. I should also mention at this time that with the DX system, the filters are locked down. The filters for deletions are set at 25 kb and 25 markers, and duplications are set at 50 kb and 50 markers. The exon and H2 systems allow you to alter the filtering settings. And so therefore, that can result in some differences in some of the cases that I will show you. The first case I'd like to describe is an adult male with cystic fibrosis. We performed CFTR full sequencing and identified one mutation, which is a known pathogenic mutation in exon 21. It is associated with pancreatic insufficiency. However, no second hit was found. It doesn't change this person's clinical diagnosis. However, it was unsatisfying to not detect a second mutation. Additionally, our copy number analysis bioinformatically failed to detect a deletion or duplication. We therefore ran the sample on the exon array kit and detected a deletion of exons 19 and 20 in the CFTR gene, providing the molecular confirmation of this patient's clinical diagnosis of cystic fibrosis. The second case I'd like to share with you is a 21-month-old female who presented to the hospital with lethargy, altered mental status, metabolic acidosis, and rhabdomyolysis. Additional studies to evaluate a fatty acid oxidation defect were negative, and the next step was to proceed with a small next-gen panel of genes associated with rhabdomyolysis. During that evaluation, a likely pathogenic change in lipin-1 was identified. This variant is located at the splice site of intron 10. Changes in lipin-1 are associated with acute recurrent myoglobinuria, an autosomal recessive disorder. And typically, individuals will either be compound heterozygotes or homozygotes for mutations in lipin-1. However, again, similar to our previous case, no second hit was found. This also includes a copy number by bioinformatic analysis. We then ran the sample on the exon array and detected a deletion of exons 20 and 21 in lipin-1. So this is two different cases now where an individual was identified to have a 2-exon deletion in a gene in a recessive disorder that was not found by next-gen sequencing or bioinformatic copy number analysis. Case 3 is a infant with multiple osteochondromas. And I have shared with you a slide of the left hand showing you with the arrows where some of the osteochondromas were identified in this individual. So clinically, we know that this is the appropriate diagnosis for this individual. In looking at the gene reviews, individuals with hereditary osteochondromas typically have alterations in EXT1 or 2. And of these cases, about 10% will be due to a copy number difference as opposed to a SNV or NDAP. We ran the Dx array in part because the clinician had ordered it, not necessarily looking for deletion of EXT1 or 2, but really just looking for any sort of large-scale chromosomal aberrations. And on the Dx assay, there were no calls made, and the result was a negative report that was generated. We then followed up with next-gen sequencing of EXT1 and 2, and we were able to identify the deletion bioinformatically. And so we decided to run this on our exon array so that we can compare it to the Dx array information. On the exon array, it did note the deletion of exon 5 through 7 in EXT1. And so when we went back to review the Dx array, although there was no call generated, this was likely because it was less than the 25 markers and 25 kb that are required for the Dx to make a call. You can note on the raw data that there is a little dip where exons 5 through 7 occur. Case number 4 is an 8-year-old male with a history of pain in his lower extremities, possible muscle weakness, mild optic atrophy, and frequent falling. The family history was significant for consanguinity, And the Dx array was run in part to look for areas of homozygosity to then narrow down the possibilities of a recessive disorder. The patient was identified to have almost 21% of the autozygome as being homozygous, which resulted in a large number of genes. However, this testing also identified an uncertain call that was a homozygous 190 base kb deletion at chromosome 4q. And so this is a gene in which deletions of exon 2 have been associated with Charcot-Marie Tooth type of disease. And when we looked at the DX raw data, you can see the large area block of homozygosity. And additionally, you can see the homozygous deletion that occurs within that block of homozygosity. However, we didn't have a really good feel for whether or not the deletion was intronic or whether or not it spilled out into the exons. And because there are case reports of deletions of exon 2 being disease-causing in this disorder, we went ahead and ran the XON array. In reviewing the calls generated by the software system, there was no call in this gene. However, if you look at the raw data, you can see the deletion between exons 1 and 2. This made us feel a little more confident that we weren't missing a diagnosis. In other words, the data appears to be pretty solid for the exon 2 in that genetic information is present there. The next case I'd like to share with you is a urea cycle disorder. And this was a female who was born and identified to have hypoglycemia, hyperammonemia, and desaturations. And with biochemical testing was identified to have a proximal urea cycle defect. So in other words, there was a very low level of citrulline. And the differential diagnosis for urea cycle disorder with absence of citrulline includes OTC, CPS1, and NAGS. So despite having a very clear biochemical diagnosis, molecularly, the diagnosis can still be vague in these situations. Because of her also being an infant of a diabetic mother and having additional complications on top of the hyperammonemia, there was concern for the possibility of a second disorder or something larger happening on a chromosomal level. Microarray was ordered. Testing did not identify any copy number changes. However, it did identify 4% of the autozygome being homozygous, again, consistent with a family history of prostate. Interestingly, we noted a large AOH region at chromosome 2, Q34, and in that large AOH region includes the CPS1 gene. As I mentioned before, using the DX platform, there was no deletion identified within this block of AOH. However, when we ran the sample on the exon array, we noted a homozygous deletion of exon 32. And so looking at the DX raw data, I have drawn in an arrow to show you that there is an absence of probe coverage over exon 32 in the CPS1 gene. However, when you look at the exon array raw data, you can clearly see very good coverage of exon 32. And this small dip that shows it's just that exon that is deleted. This next case is an incidental finding that was noted on a male child with a history of seizures who had undergone a comprehensive epilepsy panel that was not diagnostic. The physician decided to follow up with a CytoScan Dx microarray order, and testing identified a 200 kb deletion of 7p of uncertain clinical significance, because within this region, there are 3 genes listed in OMIM, including PMS2. PMS2 is one of 4 known genes known to cause hereditary non-polyposis colorectal cancer. And so this was an uncertain call to make in a otherwise healthy male child with no family history of cancer. In looking at the DX data, we saw that the deletion spanned into PMS2, but again, did not feel confident on which portion or part of PMS2 was actually deleted in this patient. Follow-up testing by XON Array identified a deletion of one of the exons within PMS2. So although the data is a little bit different, this may be in part because we're comparing HG38 to HG19. It was reassuring that there definitely is deleted material at PMS2, and reporting this out in a male child was an appropriate thing to do. The last case I want to share with you is the case of Mosaic Trisomy 9, just to illustrate what mosaic cases look like from both the Dx and XON systems. So this was a newborn male with micrognathia, cleft palate, VSD, horseshoe kidney, and hypospadias, who had had a normal prenatal microarray by amniocentesis. Because of the multiple congenital anomalies, the clinician ordered CytoScan Dx microarray, and the findings were consistent with Mosaic Trisomy 9. The physician then decided to follow up with karyotype and fish studies to determine the true level of mosaicism. Results of that additional testing identified 2 of 50 metaphase cells with trisomy 9, and interphase fish on a direct sample indicated that about 20.5% of cells showed trisomy 9. So for fun, we ran this on the XON array and compared it to the DX array. And what you can note is that both platforms both called the Mosaic Trisomy 9. And so I'd just like to conclude with how we envision using XON array in our laboratory. As individuals are evaluated in the genetics clinic, if they are identified to have intellectual disability, multiple congenital anomalies, or dysmorphic features, or autism, CytoScan Dx is still the first tier test that we use in our laboratory setting, in part because it is FDA cleared. And if negative, then we will work with the ordering clinicians to follow up with either next-gen sequencing and or CytoScan XON Array, depending on the phenotype. If there is a suspected diagnosis in an individual, the physician will order next-gen sequencing or Sanger confirmation of a single gene. And again, if that testing is negative or one hit is identified in a recessive disorder with no second hit, we will follow up with CytoScan XON Array to see if there is a CNV that was missed by the bioinformatics calling system. Additionally, although we do not offer whole exome sequencing in-house, when whole exome sequencing returns from an outside laboratory with one hit in a recessive disorder, we again can follow up with XON Array to see if a second hit was missed. And so with that, I would like to acknowledge the laboratory at Children's National. Crystal Ralph is our medical technologist who has done all of the wet bench work for the XON Array cases I presented. Dr. Meltzer has been performing the del-dup analysis bioinformatically for us. And Mary Beth is our genetic counselor that keeps us organized and on task. And so with that, I would like to open this up to any questions that you may have. And thank you for your time.
Thank you, Dr. Deleu and Dr. Kuzmana-Ozog, for your informative presentation. It is now time for our live Q&A portion of the webinar. Before we begin, a poll will pop up on your screen. If you have questions or would like additional information on the CytoScan XON Array, please check all that apply. A member of our team will contact you shortly. Now, if you have a question you'd like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So let's get started. Our first question is going to be for Dr. Deleu. How do you explain the significant improvement in QC parameters when using your in-house reference set for array data analysis?
That is actually not really new because we also observed that with our CytoScan HD array and also with the 250K SNP array that we used in the past. It's really crucial to use your own process data for within your reference set because of minor lab differences and also sort of the lab person's signature that is more or less visible in the data. And we were actually quite pleased with the significant improvements. So we were happy with the result, as you can imagine.
Now, Dr. Kuzmana-Ozog, this one is for you. Do you perform CytoScan Dx and XON Array on all samples?
Thanks for that question. No, we do not perform both Dx and XON on all samples. Some of the cases that I illustrated today, we did run both, in part to just demonstrate the differences between the two platforms. We offer Dx as a standalone test, and that is our microarray assay of choice. And that is what the physicians are ordering if they want to do a clinical microarray. We are using XON to supplement our sequencing pipeline, as well as to supplement any sort of questionable calls that are made with the Dx platform.
Now, we are getting so many good questions today, but we do only have time for a couple more. So, Dr. DeLiu, why does the XON array have better exon coverage than your average whole exome sequencing data set?
Well, I mean, I can basically only draw the conclusion based on the exome that we use, and that's the 50 MB exome enrichment. And that's because the focus of the exome is on the coding sequences, coding exons. And with the XON array, we have experienced and I've seen that also the non-coding exons are included on the coverage, and that makes a big difference, especially for exon 1, which is often not very well covered. Excuse me. So that's the big difference: coding only or coding and non-coding exons.
Is it okay if I just answer that question?
Absolutely.
That answer. So I would say, in our experience, when we're looking at copy number bioinformatically, we're comparing to other samples within that run. So anything that's not well covered across all samples, like you mentioned, exon 1, are difficult to pick up bioinformatically. Additionally, small deletions, so 1 or 2 exons, are also equally difficult to pick up bioinformatically. So the beautiful thing about the exon array is that you're really looking at that specific patient, or that individual sample, and those probes are specifically designed to cover those exons.
That was great input. Thank you, Dr. Kuzmana-Ozog. And it looks like we have time for one more question. So, Dr. Kuzmana-Ozog, how hard was it to implement XON array in your lab?
It was honestly one of the easiest things we've done in our lab since we started growing in 2013. So the beauty of the XON array is we have all the equipment, instrumentation already available in the lab. It really was just plug and play with a new kit. The techs were very comfortable with doing the wet bench prep. It didn't take them a long time to learn how to figure it out. And additionally, they were able to really run it at the same time that they're already running the DX array kits. From an FTE standpoint, it was really great. From my standpoint, on the software analysis side, having had experience with the HD software, it really was sort of, dusting off the bike and getting back on it. All of the clicking and tweaking was all very comfortable.
Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information that you provided at the time of the registration. We would like to thank our doctors for their time today and their important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. This webcast can be viewed on demand through February of 2019. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.